Chris Frederick with the Stretch Twin Institute at stretchtwin.com. I'm very excited to introduce and interview one of our moderators for our forum. We haven't quite decided the name of the forum. It could be post-traumatic stress disorder or syndrome. I think it'll come out of this interview a little bit, what we'll call it, but it's the kinds of things we see in body therapies and fascial stretch therapy. And we're opening this interview to the public. It's going to be on YouTube for the public to see because it's a very important topic. And but we're going to have the forum inside our membership only for our fascial stretch therapy practitioners, but we can all benefit from this interview. So here we go. Meaghan Murphy, welcome.
Hi.
Hi.
Thanks for having me.
You're quite welcome. So let's begin with, let's just start with PTSD, if it's still called that. Can you just, well, actually, you know what? Tell us a little bit about yourself first, and then we'll talk about PTSD. How's that?
Okay. My background, I'm a licensed associate counselor in the state of New Jersey. I have my master's in counseling psychology and a second in pastoral ministry from Boston College. My bachelor's, which doesn't make any sense, is in chemical engineering. My background in terms of working in the mental health field is I worked in emergency psychology, individuals who are dealing in psychiatric crisis, homicidal, suicidal, and psychotic, along with people dealing with severe anxiety, depression, post-traumatic stress disorder, and acute stress disorder. From there, I worked in access and short-term crisis counseling, and now I've kind of transitioned. I now work as a full-time personal trainer and fascial stretch therapist.
Well, I feel so good talking to you because if someone starts to cry on my table when I'm working on them, you've been through homicide, and suicidal people with those tendencies. What's a little crying on the table? It feels like you're overqualified, and I'm glad you are, because, yeah, you can handle explaining why people may cry or have other phenomena and reactions, mind and body, when we work on people. So maybe let's start talking about it. What can happen, and how would you classify things that can happen in a session, massage, fascial stretch therapy, and any kind of therapy on the table, whenever you're working with a client or patient?
There's a couple of things that I've noticed. An individual might, at that point in time when you expect the tissue to release or to give way, suddenly it will freeze. You just hit a stopping point where there was no indication of one. The client may have trouble relaxing despite anything you try and do. They may, the term being called dissociate, or start babbling, or all of a sudden become not entirely coherent or almost out of body on the table, which is their body separating themselves from, or their mind separating themselves from their body, for a lack of a better way to describe that. And if I'm speaking to other fascial stretch therapists, I'm sure you've experienced it at some point or another. Something changes with the client, you hit a roadblock, or they're just not receiving what you're trying to help them with. That's usually an indication that you might be either triggering something that they don't even know that they have to deal with, or maybe they didn't tell you that they're working through something outside of your session.
Mm-hmm.
And that's an opportunity where you can be like, hey, maybe what's going on here? What do you feel there? And kind of read what their emotional state is. Not everyone's ready to acknowledge it, but as therapists, if we have the ability to be aware that this becomes something that can be on our table, we can take that moment that for the client might be very threatening or imposing, and we can change that context so that it becomes more of a safe, collaborative environment for the stretch,
Right.
rather than them getting off our table and never coming back.
Can we start with maybe, I don't know if this is a good idea to talk about maybe the most common manifestations, and it doesn't have to be from PTSD. It could be simply they're crying for another reason, but crying, maybe shaking, or whatever you deem as the top three things that you often see with people, if that makes sense to classify. And if we could just talk about what should we be looking for, and when someone cries, let's start with crying. It could be many things. It could actually be they're in pain. And then oftentimes when I ask someone when they're crying, are you in pain? They say no.
Right.
And that's a first sign for me. And I don't know if it's accurate, but it's like, okay, it's something else I'm thinking. And so we have to
Right.
handle it. And then I watch the breathing and autonomic, the autonomic and nervous system, looking for other things, color changes. But anyway, I'm going to throw that to you in terms of what is there such thing as the top three common things you might see that may indicate PTSD is present, or worse, other traumas?
Um,
Or is that too simplified?
it's not too simplified. What you might start to see is restlessness.
Ah,
Or maybe they're going to start to overanalyze what you're doing
with
to kind of
questioning, you mean?
question you, getting out of the experience.
Ah.
Why are you doing? How is this connected?
So let's latch on to one of those. Let's talk about what's very common. Like, is it the avoidance by asking lots of questions? Would you see that? What do you see that indicates to you, okay, we've got some trauma here, most likely, and then you confirm it later,
I've seen crying.
Okay,
I've seen an entire area of the body shut down. So all
let's
of a
start.
sudden,
Let's
yeah.
start with that because I've seen it and other people talk about it. What do we do? We're not psychologists as FST practitioners and massage therapists and other professionals. What do we do when that happens?
So what I've found works is a couple of things. A, acknowledge that wherever you've gone isn't safe for the person. You don't have to tell them that in that many way, but back out of that stretch.
Okay.
And the last thing you really want to do is say, I know what I'm doing, I've got this. Because as far as they're concerned, they're in a threatened position, and you don't know why. PTSD can develop from someone falling down a flight of stairs to some of those really deep, dark, ugly stuff we see on TV.
Mm-hmm.
So, it can be any of those. So you don't know what you did that triggered it, but something in that area, whether it's the hip, oftentimes I've found it's the hip, but it can also be the shoulder or the ankle. I've seen. Back out, and then go broad. I've found that if it's working in the psoas or the hip flexor, if I come out and I start more general with traction, circumduction, maybe low back stuff, kind of distract the tissue a little bit, and then ease my way back in, that's helped. Or
So,
I've had, sorry,
so
go ahead.
I'm going to pursue that a little bit. So, if you don't mind, so would you get off if you realize you just let's say stretch the psoas, you have a crying reaction? Would you, and I know that you can't necessarily throw this into a recipe that works in every person, but would you go to the antagonist muscle, or would you just get away from the psoas? You can go anywhere from the head to the foot. Is there kind of a default place, or do you, or not?
If someone's crying on the table, that's actually not necessarily a terrible sign because it's a release of the emotion. Their body is letting it go, which is, to me, an excellent thing. I may not want to go, say, to the piriformis or to the glutes on the other side of that right away
Mm-hmm.
on the same leg
Really?
because that psoas is open. I don't want to close it.
Ah,
So I might go to the other leg or the opposite shoulder to go around along that spiral line to continue to open it up.
that's really interesting. Yeah, I never thought of it that way.
Because if it's been locked down, who knows for how long? And again, what I really try and do when I work with people who are dealing with this is, even though, yes, I have that mental health background, I very much stay the fascial stretch therapist, and I let them take that. I create the open space that if they want to talk about things, they can. But I'm not going to necessarily dive into what's going on with them unless they need to share it with me. But I will allow that tissue to stay open to go along. So I'll think, where along this fascial line can I open up again? If that fascia was around the psoas was tight, I'm going to guess that the opposite shoulder has been pulled down towards it. So let's loosen that up too.
So you go distal.
Yeah.
Sort of, it's still related to that fascial line or fascial chain location of where you were locally, but then you go more globally. I mean, correct me if I'm wrong. I'm just talking out loud, thinking out loud. You go globally to a related area in which, let's say, fascial line or chain in which the psoas, let's say, sits. So if you go to the contralateral shoulder for the spiral line, psoas is in the deep front line. You're still working in a relationship way of keeping it open and not closing it. So that's a different strategy that we could all benefit from, to think of it that way. I think it's pretty amazing. That'll help. Okay. My mind is just like buzzing with all kinds of ideas now. You just opened up Pandora's box in a good way, I think. um, so the other concept I want to bring in was when I see someone cry and I just stretch the tissue. When, let's say, if I overstretch someone by accident, it happens to all of us.
Yes.
I think of it, okay, I just overstretched something. Let me shorten the tissue without
Yeah.
necessarily closing. I'm not going to go to the piriformis for the psoas. Let's talk about the psoas still. Stick with it. I will. It's a strain counter strain concept. So in physical therapy, we have something osteopathy. It's called strain counter strain. Lawrence Jones was an osteopath who I believe came up with those concepts. But it makes so much sense. It's the yin and the yang. You did too much movement. You open it up too much. Let's reduce the stress. So strain, and actually usually strain counter strain probably does mean close it a little bit, or just take the strain off, take it off stretch and let it shrink, or if you will, or return to its original length, de-stress it.
Yes.
And that really works. If I do that within a few seconds, they mentally and emotionally forget about the pain.
Yes.
And usually I take them in a pattern that's the opposite, is in the opposite direction. So if it's a lateral line I open and they hurt, and I hurt something, I overstretch them, I will go and close that lateral line for just a second and come back to neutral. And it's like we just start all over again. And mentally, emotionally, they forget about it,
Yeah.
which I think is
That's,
pretty awesome.
yeah. I really like that idea, particularly if you've hit an area that someone's not ready to acknowledge yet.
Yeah.
Like on those points when, and you know when. Um, I guess when I'm talking about when you're leaving something open, um, if you're sticking with the psoas, rather than it being too open, for most people it's going to finally be going back to neutral where it hasn't been in a while.
Right.
There's like a PTSD reaction. So by leaving it open, I'm simply I'm not going to work on it for a little while. I'm going to give that a rest and back away.
Yeah, I like that. Mm-hmm.
Um, but the counter strain, I like that because that might be a great way to end a session.
Mm-hmm.
Afterwards, coming back to it and kind of, reducing it just to bring it back to a place where it's not too much new space that they're not used to.
It's
So
almost, yeah, sorry. It's almost the concept of like what we do in stretching after releasing restrictions in the body and giving a lot of mobility. We have to compress the body a little bit we call it stabilize. You're not really compressing it so now they're squashed after just lengthening everything, but it's bringing the body a little in towards a stable reference point so that when they get off the table they feel stable and not sort of loosey-goosey all over the place with all this feeling of too much mobility and they don't know what to do with it. So I think that concept, it works with that philosophy.
yeah, that works well. And on the opposite side, for later on, if hopefully we get to talk about maybe not in this interview, but how to engage with other mental health practitioners,
Mm-hmm.
and they don't understand what the stretching is, or maybe they see that there's some vulnerability in opening someone up too much. You can kind of compare that to how talk therapy works. That in a
Well,
therapy, you open people up and then you put them back together so they can function normally in the real world.
yeah, and I think that is a topic for another conversation. Going deeper into that, that is a definite strategy we need to talk about. But sticking with what we started, what we just opened up,
Excited.
sticking with the key muscle of the psoas, lying in the deep front line, deep front chain, deep front net, we're starting to call it in fascial stretch therapy, like as in fascial net. Um, we opened it. They start to cry. We move away from it. They settle down. What's the strategy now that we went distal to the opposite shoulder, for example, and everything's working fine? Do we revisit the psoas in that session just to see, hey, maybe they're ready now for me to go in there because I went distal? Or is it something that I have to wait till the next session, or does that depend on the person?
Most of the time, that'll depend on the person. I have
Yeah.
found that less is so much more here because you have no idea what that emotion is connected to or what that brings up.
Mm.
Most of the time, we won't know. But you might get a text message 2 days later saying, if you open it up too often, too much, you could get a text message 2 days later saying, hey, I'm feeling uncomfortable with what we're doing. Because you've opened them up, you may have flooded them with memories, they may be experiencing emotions they haven't experienced in a while. And that, at all times, we have to be able to send them back into the world to function in their lives. So that emotional component of it, less is so much more.
It's really interesting. It's just interesting how it parallels when we look at just from a mechanical point of view, when you overstimulate the nervous system, let's say a nerve, a peripheral nerve, if you overstretch a nerve, like a sciatic nerve, and they don't have sciatica, let's say you, Meaghan, I stretch your sciatic nerve too much, and you never had a problem there. I will get that phone call. It'll be a delayed reaction. You won't feel it necessarily right there and then. I take the stress off. You'll be like, whoa, that was a little too much. And you're like, oops, sorry. And then I get a phone call a couple hours later, and you're like, oh boy, it's pins and needles. It's numbness. And I'm like, oh crap, I really overdid it. I overstressed. And it's a delayed reaction, purely from a mechanical overstretch of the nerve. That's the best case scenario. Worst case scenario is they have to go to the emergency room with an outright acute sciatica flare-up. That would be the worst case scenario. That's never happened to me, and I've never heard that happen to any students. At least no one told me that. So it's just interesting when you think about opening up a past trauma that's, for lack of a better term, stuck in the body, still resides in the body, and mind, of course, body, mind. Now we're touching it, we're probing it, we're nudging it, sticking it a little bit. And it's like we have to be responsible as therapists, trainers, practitioners to realize what we're doing there, the possibilities, and less is more. And perhaps, it's not all going to happen today that we release something. And so the strategy would be think about maybe, especially if we're not trained in mental health or dealing with PTSD. It's like, let's go away and stay away for a while and gauge the client-patient response. Because if they're willing and let you go back there, knowing that it's been stimulated, I would imagine, and you seek almost a verbal contract permission with the client saying, hey, you think you're ready for that again? What we did last session, where we do a little bit of opening of that area. Are you okay with us doing that today? And they could say anything from yeah to no, or maybe we'll wait another session. Something in between. Would that be an appropriate strategy?
Would be awesome, because that gives you that gives you so much information. If they've come back to you, they're starting to build trust. You're building rapport with them. So if you honor the answer that they give you, whether they say yes, no, maybe so, or they're not sure, even a I'm not sure, maybe you want to stay away from that, because you don't know what their home environment is, if they have the supports in place to deal with whatever it is you're releasing. So do they have a safety net to catch them if all of a sudden they're, a little bit off for a day or two? And some do, and they're like, yeah, let's do this. Let's get through this. Right. And some are like, I'm not ready. But the more you respect their answer, the more trust, more rapport, the even better response you'll have the next time you go there.
Well, you have to develop a relationship, right?
Right.
And it's like the first date.
Right.
Kind of thing, right? So you have to cultivate that, and then once they trust you and realize they're in a safe place each time they return back to you, that it's non-threatening, that you don't overdo things or force them to do things on the table based on your agenda, we're going to fix this. If they realize you're not that kind of practitioner, then I think they're more willing to form that partnership to do this together kind of thing and work with the body and mind to allow their body to open up sort of when they're ready.
Correct.
Awesome.
And I'm just going to cycle back as like the number one, if you could say the number one thing that I've found, just to bring this back in terms of signs where I'm starting to think about something's going on, is the straps.
Oh, say it again. Is what?
Using the straps.
Using our straps that we use in FST.
Putting a leg underneath the straps.
Interesting.
If they're heightened or if something has happened, if their behavior changes or they become extremely uncomfortable, that's a signal to me to take them out, and I have to adjust the way I'm going to stretch them.
Very, very good. Yeah, you can do a lot of our routines without straps, and especially with someone like that, you don't need that kind of stabilization or holding the limb, even though they're pretty loose straps. I mean, your leg can slide around. You can, I
Right.
guess, you can also preference the strap by introducing the person to that concept of what the strap is doing, and you're free to pull out. You're free. It will not restrain you. You can slide around in the straps. It doesn't really fixate anything. I think
Right.
maybe it may not mean anything to them, but at least if you at least premise what the straps are in as non-threatening a way as possible, then it'll be up, and then we'll say, "Do you want to go under the straps or not?" Kind of thing. Leave it up to them, and they may
Yep.
decide, "Yeah, okay, that sounds I can handle that," and they still may not handle it. Like 10 minutes into, they start sweating. Let's come out of the straps.
Yes, it's a good sign.
Yeah, they thought they could, but they couldn't. And
Right.
then others know that no, those black straps, I'm not going under that. And you're like, that's
Right.
fine. We can do everything we need to do without the straps.
Hmm.
Cool. Well, I think on that note, because this is a real mile deep topic, let's end that. And what do we have to look forward to? We talked about crying. What should we discuss on the next session together? Shaking. I mean, does it matter what it is, the phenomena? Because sometimes people will just shake. It's almost upsetting to the therapist. Oh my God, are they having a seizure? For those not trained in this, it's kind of scary enough for them to cry, especially if it's like real crying, like not
Right.
just sobbing, but they're breaking down crying. And that, how do we handle, you know, that's hard for us to handle. Do we walk out of the room? Okay, we know, give them a box of Kleenex. Then what? So maybe we should talk about stuff like that.
That would be a great topic.
Yeah, we need to know that.
How to be in that environment.
How
We
to
can.
be in that environment and give the client what they need, but also make us feel confident and secure with what's happening. Because some of us, I'm sure, will start crying with them. I just thought about that. I've never
Yep.
done that. I felt empathy, tremendous empathy, but I don't want to start imagining what could it be, because then I might start crying like, oh my God, they've been attacked. And yeah,
Right.
that could be true, but that's not. I need to maintain my stability, my mental stability.
Yeah.
And
We can do.
some of us therapists are very, very empathetic in terms of maybe even being an empath, and they feel it even before the client comes in to the room. And they feel the presence of trauma everywhere and the energetic change. That's some people are like that. So maybe we can reserve the next session to talk about, maybe from our point of view as therapists and trainers, when we have someone on the table, how do we handle ourselves? How can we handle ourselves?
That sounds like an excellent topic.
So the
I like that.
person, so the person on the table will feel comfortable to go through the process, to continue to go through the process.
Yes.
Awesome. All right. Well, we'll end it on that note. Meaghan Murphy, fascial stretch specialist. Chris Frederick here interviewing Meaghan. Great start to the whole family of traumatic disorders, post-traumatic stress disorder, and friends and foes. We have a lot to talk about. So I'm excited to get this going. For those who are FST practitioners, look for Meaghan's forum on these topics in our brand new website. And for others, enjoy this continued series on YouTube. Till then, TTFN, ta-ta for now. Thank you.
Bye.
Bye-bye.